Good morning. The use of ultrasound has been widely accepted since the late 1970s as the initial diagnostic imaging modality of choice for evaluating gallbladder pathology. The quality of the ultrasound can be influenced by a variety of factors. As distance traveled by ultrasonic waves increases, there is greater absorption and dispersion of energy into the surrounding tissues. Adipose tissue also attenuates ultrasound energy, particularly at higher frequencies. As body mass index increases, both abdominal wall thickness and adiposity also tend to increase. To date, no study has been performed looking at the effect that BMI might have on ultrasound in accurately determining the thickness of gallbladder wall as a marker for cholecystitis. The purpose of this study was to determine if such a relationship exists. Our hypothesis was that right upper quadrant ultrasound underestimates true gallbladder wall thickness in obese patients. We performed a retrospective review of patients who underwent cholecystectomy and compared gallbladder wall thickness measured on ultrasound to thickness on final pathology. The results were analyzed in relation to the patient's BMI using the standard BMI categories, ranging from underweight to obese category 3. In addition, we looked at several other secondary factors for comparison, including age, presence of diabetes, sex, and whether the case was performed urgently or electively. We obtained our data from the electronic medical record from 2012 to 2015 and statistically assessed both accuracy or bias and precision. Accuracy was based on the mean difference of the ultrasound measurement minus the pathologic measurement. Reproducibility of the ultrasound, as measured by precision, was set at a range between plus or minus 0.1 centimeters of the pathologic measurement. These are the demographic factors of the study population. Of the 601 patients, 484 had paired data measurements on ultrasound and pathology. Median age was 33, and 70% of patients were female. For BMI categories, 25% were normal weight, 37% overweight, and 39% obese. Just over half of the patients had urgently performed cases. The first question we assessed statistically was, are certain demographic factors associated with a person presenting with a thickened gallbladder? The generated odds ratio indicated that male sex, an urgently performed case, and advanced age were all associated with findings of a thickened gallbladder on pathology. While no significant increase in odds ratio was generated based on BMI, prevalence of increased gallbladder wall thickness tended to increase as BMI category increased. Percent of individuals with thickened gallbladders were 19, 24, and 27% for the categories of normal weight, overweight, and obese, respectively. We then looked at the results the relationship between our demographic factors, gallbladder wall thickening, and sonographic measurements. For our primary endpoint, we found no statistically significant difference in accuracy or precision of the ultrasound measurement of the gallbladder wall based on BMI. However, some of our secondary endpoints of the study did have significant findings. Significant findings were, to summarize, no bias was found to be related to any of the demographic factors of age, sex, urgency, or diabetes. There was a negative correlation between the actual pathologic thickness of the gallbladder and the accuracy of the ultrasound. Precision decreased with pathologic thickening, advanced age, male gender, and urgently performed cases. This first graph illustrates precision based on BMI. As you can see, there is relatively little difference in the precision of the ultrasound when categorized by normal weight, overweight, and obese. This graph shows the precision relationship between actual gallbladder wall thickness and the findings on the ultrasound. As wall thickness increased above the upper limit of normal, ultrasound became much less precise at measuring actual pathologic thickness. The ultrasound actually tended to underestimate more and more as the wall became more thickened, as you can see in this follow-up graph. This graph demonstrates the relationship between age and precision. Age, particularly over the age of 70, correlated with less precision. There was a trend towards bias with underestimation increasing as age increased. However, these results were not statistically significant as seen in this follow-up graph, and actually over the age of 70, the trend no longer became consistent. The results of this study do not support our hypothesis that obesity is associated with decreased accuracy of the right upper quadrant ultrasound in determining gallbladder wall thickness. However, the majority of our patients included in this study were healthy, non-obese, active duty individuals. Additionally, the majority of our patients who were obese category 1, with a small proportion of obese category 2 and 3 in our study population. It's possible that a significant decrease in ultrasound accuracy may not occur until a patient is very severely obese. However, our study was not adequately powered in order to observe such an effect. It's unsurprising that cases performed urgently would have less precise measurements than elective cases. Those performed urgently were often done at night and on an expedient basis. Due to decreased time to evaluate, it's not unreasonable that these measurements would be less exact. Additionally, on review of the technique used by our ultrasonographers to measure the gallbladder, it was discovered that our institution does not have a standardized protocol for how these measurements are obtained. This also significantly affected the reproducibility of our study. The relationship between pathologic thickness and age was interesting. Precision decreased as pathologic thickness and age increased. Thickened gallbladders tended to be underestimated in thickness, and although not statistically significant in difference, there was a bias that existed based on age. This phenomenon in the older population may be due to tendency for older patients to present with a pathologically thickened gallbladder. Given the findings of this study, it's reasonable to assume in the clinical setting that a right upper quadrant ultrasound for an obese patient would have equal accuracy in predicting actual wall thickness to someone of normal, healthy weight. Special attention should be observed nonetheless to elderly individuals as well as those patients who present warranting urgent intervention, as these populations in particular tend to present with thickened gallbladders. Given the propensity for significant imprecision in measuring wall thickness for elderly patients, as well as a trend towards underestimation, the clinician should not necessarily be reassured by normal gallbladder wall thickness on ultrasound, particularly if the rest of the patient's history and laboratory findings support the diagnosis of acute cholecystitis. Thank you for your time. I'd be happy to entertain questions.
The floor is open for questions. And again, state your name and where you're from.
Good morning. My name is Major Joel Brockmeyer. I'm at Womack Army Medical Center. Since ultrasound is so user-dependent, did you guys standardize in any way for the ultrasound techs and their level of training or experience?
Unfortunately, we did not. We realized after the study was performed, in terms of there's a standard way that the ultrasound should be measured by the sonographers. However, our institution didn't have a protocol for it, and on talking with many of the techs, they all have different techniques of doing it, so that was definitely a problem for the study.
I do have a question. So ultrasound definitely is used, particularly for that diagnosis, and a lot of the clinicians, especially from the ER, use those numbers. So how does this change your management after this study? Because basically it always is the radiologist who says, please clinically correlate, right? But the reality, though, is there are times where the clinical picture is not there and the radiologists help us with that diagnosis. So how does it change?
I think it can be used as a tool to help us keep everything in perspective. I think it's important to know that, one, we don't just look at the thickness. That's one of the things, although it's a good measure for this study, we have to, like you said, look at the whole clinical picture. But I think in terms of how it would alter my management, I think if the measurement was necessarily with it, borderline measurement for an older person in particular, but the rest of the clinical history supported the diagnosis, I would have a stronger tendency to take that person to the operating room.
Thank you.